Welcome to the AMDA webinar titled Respiratory Muscle Strength Training in Pompe Disease. Your speaker is Harrison N. Jones, PhD, BRS-S, CCC-SLP, Assistant Professor, Department of Surgery, Division of Speech Pathology and Audiology at Duke University. Dr. Jones received his PhD from the University of Florida in Rehabilitation Science in 2007. He has been practicing as a speech pathologist for over 10 years and continues to spend half his time in the clinic. Dr. Jones has published many peer-reviewed journal articles. Additionally, he is co-author of the book Dysphagia in Movement Disorders, co-editor in Dysphagia in Rare Conditions, and the author of many book chapters. His current research program is focused on speech, swallowing, and respiratory disorders in genetic diseases across the lifespan and their rehabilitation via exercise-based behavioral approaches. Currently funded research projects are focused on adults and children with Down syndrome and Pompe disease. Operator assistance is available at any time during this conference by pressing £0. A question and answer session will follow the presentation. You may send chat questions at any time during the webinar using the chat window indicated by a speech bubble icon located to the right of the presentation. A recording of this webinar will be posted onto the AMDA website. I'll now turn the call over to our Dr. Jones. Please begin.
Okay, good morning or afternoon to everyone out there. It's a little bit strange to be talking, but not seeing anyone or no eye contact, but it looks like there's a lot of participants online joining us. I thank Michelle for the nice introduction. I am Harrison Jones from Duke University and would like to talk about respiratory muscle strength training, or RMST, in Pompe disease. It's my pleasure to be here today talking on behalf of the Acid Maltase Deficiency Association, and thank you for the invitation. So as a brief overview of the lecture, planning to spend about 45 minutes or so speaking, and that'll leave us 10 or 15 minutes for questions. The talk will include an overview of respiratory muscle weakness in neuromuscular diseases with emphasis on the infantile and late onset forms of Pompe disease. Again, there'll be a focus on the respiratory muscle systems and explanation of what that actually consists of. We'll talk about RMST, or again, respiratory muscle strength training, which is an exercise-based treatment for respiratory muscle weakness, which uses respiratory trainers to provide submaximal resistance training. I have some preliminary data that I'd like to share with the listeners, both clinical and experimental, and have a few conclusions to finish this off. All right, so I'll proceed. So for a moment, let's talk about respiratory muscle weakness in neuromuscular disease in general, which I feel comfortable that Pompe disease would fall under the classification of neuromuscular disease, depending on your particular background in medicine and such. But respiratory muscle weakness is a very common problem in individuals with almost all forms of neuromuscular disease. It results in substantial morbidity and mortality, again, really across neuromuscular diseases, and that includes both the infantile and late onset forms of Pompe disease. Although the patterns of involvement vary across individuals and across diseases, certainly, respiratory weakness in neuromuscular disease typically affects both the inspiratory and expiratory muscle systems. So when I say muscle systems, I'm really using that to refer to the fact that there's not a particular inspiratory muscle or a particular expiratory muscle. There's multiple muscles involved with both inspiration, which is breathing in, of course, and expiration, which is breathing out. The progressive respiratory muscle weakness, which is encountered in neuromuscular disease, has a broad range of negative effects on ventilation, gas exchange, cardiac function, sleep, and additional upper airway functions such as cough, swallow, and speech. So what muscles are we actually talking about here? This is a picture that's used with permission of Plural Publishing from a book entitled Speech Breathing Disorders by Tom Hickson and Jeanette Hoyt. And this picture illustrates the muscles which comprise the diaphragm. The diaphragm is the primary muscle of inspiration, but additional muscles also contribute. And as we look through these pictures, please note really how extensive the respiratory mechanism in terms of musculature really is. These are muscles of the ribcage wall. These muscles are likely involved with both inspiration and expiration. Again, they are really, the muscles really involve the entire trunk. And again, those are the muscles of the ribcage wall. Some more muscles of the ribcage wall. Using my pointer here, trying to, let's see, add it. Some of these intercostal muscles here that I'm pointing to are particularly, there's some of the accessory muscles of inspiration. So they are contributing to inspiration for maybe about 30%. The diaphragm is the primary muscle of inspiration, but these accessory intercostal muscles also contribute approximately perhaps 30%. Here we see the muscles of the abdominal wall. These are primarily expiratory muscles used to generate the force for expiration. So again, the respiratory muscle system, I'm going to go back just one second, is quite extensive, really involving the entire trunk, from just below the neck all the way down a little bit past to the pelvis. So what about respiratory respiratory weakness in Pompe disease? Well, unfortunately, respiratory muscle weakness is almost invariably present in individuals with Pompe disease. Untreated disease progression is marked by increased respiratory distress in most. In a natural history study, and this is the infantile form right now, in the natural history study, respiratory distress was present at a median age of about 4 months. These were individuals that did not receive treatment with enzyme replacement therapy. They required 24-hour per day ventilatory support at 5.9 months, and death typically followed at a median age of 8.9 months, typically due to cardiorespiratory failure. Somewhat similarly, but also differently, respiratory muscle weakness is also prominent in the late onset form of Pompe disease. Although the symptoms of the late onset form of Pompe disease are less severe, respiratory failure or insufficiency may in some cases be the presenting symptom. In an untreated cohort, respiratory muscle weakness was present in 90% of subjects, and expiratory muscle strength declined 7.3% over 1 year. Symptoms that patients with late-onset Pompe may perceive, which are suggestive of possible respiratory weakness, include dyspnea on exertion or shortness of breath. When working hard for physical exertion, and excuse me. In late onset Pompe disease, respiratory weakness increases with disease progression and also causes a variety of negative symptoms, such as decreased vital capacity, sleep disturbances, weak cough, and impaired pulmonary toilet, respiratory insufficiency, and even acute respiratory failure. Very significantly, respiratory failure is the most common cause of death in adults with Pompe disease. So this is something that's very that really hits close to home. So, of course, I'm sure most of the audience is familiar with enzyme replacement therapy, and ERT has indeed really changed the treatment landscape of Pompe disease and altered the natural course of the illness. That being said, respiratory weakness persists. So in the infantile form, long-term improvements associated with enzyme replacement therapy included improvements in survival, respiratory function, cardiomyopathy, and motor function. In the late onset form of Pompe disease, enzyme replacement therapy has been shown to benefit motor function and stabilize respiratory function over 18 months. And based on data that are the data that are currently available, the respiratory strength increases, which are measured with maximum inspiratory pressure, or MIP, and maximum expiratory pressure, or MEP, generally occur shortly after the initiation of ERT in late onset Pompe disease, have a magnitude of about 3 to 4%, and generally plateau between weeks 12 and 26. So essentially, the response, however, to ERT is often suboptimal in terms of treating respiratory weakness. Skeletal muscles, which include the respiratory muscles, the response is often suboptimal, especially compared to the pronounced effects of ERT on, for instance, cardiac muscles in the infantile form. So, despite the remarkable advances that have been made in the clinical management and our scientific understanding of Pompe disease, respiratory weakness at this point and associated morbidity and mortality remains a major therapeutic challenge for both children and adults with Pompe disease. So what about what I'm here to talk about, respiratory muscle strength training, or RMS respiratory pressure, increased from 27 to 37%. As we talked about previously, during RMST, the patient required emergency abdominal surgery and recovery, which forced an approximate 2 month or 10-week, I believe, withdrawal from RMST. Upon return for RMST, the strength enhancements were relatively preserved, and the patient also voiced his belief that that his increased respiratory strength helped him wean more quickly from the ventilator following his surgery. And again, these MIP and MEP values of 57 and 76 centimeters of water pressure upon return suggest persistent respiratory muscle strength enhancements. These data come from a paper that we published in Molecular Genetics and Metabolism later in the year. All right, and then our second clinical case that I'd like to discuss, a 64-year-old female. And we, again, the blue lines are with the X's are representing expiratory pressure, or MEP, maximum expiratory pressure, while these red lines here are representing MIP, or maximum inspiratory pressure. We initiated with treatment with EMST only, while we continued to baseline inspiratory muscle performance. So with the introduction of EMST, or expiratory muscle strength training here, we see a progressive and steady increase in expiratory muscle strength throughout the course of the study. I thought I had my pointer on. I apologize. Here, we're baselining the inspiratory muscles and have not began training them. And although there's a lot of variability here, I would say the line of best fit is relatively flat. Here is where inspiratory muscle strength training is initiated, and we see a slow and steady progression of inspiratory muscle strength over the course of the study. So patient 2 also demonstrated inspiratory and expiratory muscle strength enhancements during RMST in a progressive and systematic fashion. Over 32 weeks of expiratory muscle strength training, MEP increased 73% from 37 to 64 centimeters of water pressure, while maximum inspiratory pressure, or MIP, increased 48% over 22 weeks of IMST from 28 to 41 centimeters of H2O. Predicted MIP, or inspiratory pressure again, increased from 36 to 53%, and predicted MEP increased from 26 to 31%. And again, these were both clinical patients we saw for routine clinical services. We made these observations, which were now awaiting their publication. And with these data, we submitted a grant for some additional study based on these preliminary pilot clinical data. So I'd like to briefly discuss some of the experimental data which we've now collected. So unfortunately, I'm not able to share this slide with you right now, but in front of me I have our experimental case 1, an individual with late-onset Pompe disease. This individual is participating in our research here, which is a single-subject experimental design in which each individual serves as their own control. And then we replicate the experiment over multiple subjects. This involves an extended baseline testing period, an intervention of 3 months, and then a post-test period. And then the post-test is followed by a 3-month withdrawal. So the entire study is about 6 months and 2 days from the beginning until the end. It again starts with 2 days of baseline testing, which are consecutive, and over those days, our primary dependent measures are MIP and MEP, maximum inspiratory and expiratory pressures, and we want to obtain multiple baselines and really establish what pre-treatment function is like. So for this individual, we obtain 8 baselines of both MEP and MIP. And then with intervention, we again see slow and steady responses in both inspiratory and expiratory strength as a result of RMST. And then when we did post-test following 3 months of training, these strength enhancements were rather remarkable. For this case 1, expiratory muscle strength, or MEP, maximum expiratory pressure, increased almost 2 standard deviations. So the baseline was approximately, for maximum expiratory pressure, was approximately 32.5 or so, and following training, it increased to 47.75 centimeters of H2O. Again, this represents a change of 2 standard deviations in baseline function, which is quite remarkable. So the preliminary effect size data for the expiratory muscles is really substantial. The inspiratory muscles also demonstrated a brisk, robust response, and although it wasn't an effect size of 1.93 like it was for the expiratory muscles, it was an effect size of over 1, indicating a change of a change in function of over 1 standard deviation, which is a really large change. We have a second case, which again I'm not able to share the slide with you right now, but this individual is our first subject or patient with the infantile form of Pompe disease. The same experiment was repeated, which was a 6-month, 2-day study. Baseline performance was established over 2 consecutive days of testing, and then post-test function was established over 2 days of consecutive testing. In the middle was 3 months of RMST, and we saw patients every 2 weeks to obtain their MIP and MEP, calibrate their training device, and so forth. Although this subject presented with quite a bit more variability in performance throughout the study, we also were able to determine a robust effect of the expiratory muscle strength training, whereas with the inspiratory muscles, no effect was seen. But given this subject's variability and some of the other challenges they brought forth, we were really pleased to see an effect size showing a pretty strong treatment effect in our first case of treating infantile Pompe disease and respiratory weakness with EMST and RMST, excuse me. So, in conclusion, RMST appears really promising as an adjunctive treatment for respiratory weakness in Pompe disease to ERT. Future studies with a wider repertoire of outcome measures are needed and are in fact in progress here at Duke. And additional investigations into the role of RMST in other neuromuscular diseases are desperately needed. Areas of future study, again, I think that the study of RMST and applying it to other forms of neuromuscular disease certainly warrants further consideration and study. Additional parameters that require investigation is the dosage or the intensity of treatment, any possible negative effects of exercise, which has frequently been a concern in neuromuscular diseases, although there's really no evidence to support any deleterious effects of exercise in neuromuscular disease. In addition, it would be important to determine the effects on related systems such as, for instance, cough or speech function. I would like to make some acknowledgments and disclosures before opening things up for questions, but funding for this project was provided to myself and Duke University by the Genzyme Corporation, and I'd like to thank my colleagues and patients and subjects who participated. So many thanks to, again, the clinical and experimental RMST participants, Dr. Priya Krishnani, my closest collaborator here at Duke, Michelle Canfield, the study coordinator, Laura Case, a physical therapist working on the study, Richard Kravitz from pulmonary medicine, Tranda Moss and Katie Strollo, both speech pathologists applying the treatment. Randy Roby is our statistical consultant from the University of Virginia. Jay Rosenbeck, my PhD mentor who started me along this track, and Jeff Sank from the respiratory therapy, from the pediatric pulmonary function testing lab. I thank you very much for listening and would like to open the floor for questions and invite Michelle back to help facilitate that.
Thank you, Dr. Jones. And we also have some chat questions. But for those of you listeners who have dialed in, you can ask audio questions by pressing 7# on your telephone. You'll be placed on queue in order received. Wait for your name to be announced and be prepared to ask your question. Again, 7# on your telephone to queue up for audio questions or continue to send chat questions.
So, and should I begin to answer some of the questions that I see here in front of me?
Please, feel free.
Okay. So, the first question was, in studies where strength returned to baseline, was that while exercise continued or had exercise ceased? Those are experiments in which exercise ceased. And, of course, that's a very sensible question. If we believe in that RMST is an exercise-based approach to treatment, then it only makes sense that if we want these effects to be maximized, that exercise must continue. That being said, however, even in the studies which a return to strength was noted, say following 12 months of withdrawal of the exercise, even then benefits of the treatment were observed. Another question here is, could RMST be suitable for a patient on a ventilator? I think that's something in the future that is very much a possibility. Right now, we're in the very preliminary stages of this work, and we were looking for participants who were most likely to present with a positive outcome. But as we continue to explore this treatment, there's no reason why RMST can't be used with people on a ventilator. It can be placed in line with their ventilator systems, and certainly if people can go for short periods of time off the ventilator, that's another way to apply RMST in such a setting. But absolutely, I think that's something for a future study, and we use RMST in patient populations here, say at Duke Hospital, not with Pompe disease, though that certainly have that are on a ventilator, and one of our goals for using RMST is to help facilitate ventilator weaning. So absolutely could be. So somebody else asked, at what level of reduced MIP and MEP would I recommend starting RMST? So if I'm understanding this question, when should RMST be initiated for someone with decreased respiratory muscle strength? As a scientist and clinician, I certainly would recommend early treatment rather than late treatment. We feel that late treatment may be associated with changes in, say, muscle architecture that are permanent and somehow in some ways restrict muscle strength enhancements. So in that regard, I feel that the exercise should start fairly soon when we begin to see these declines. Additionally, more and more we talk about the possible neuroprotective effects of exercise, and there may turn out to be that there are some neuroprotective qualities may help preserve function over time to early intervention. So I think that earlier is better, and some of the participants that are now enrolled in the study and currently undergoing treatment, one of them really doesn't present with respiratory muscle weakness yet, and we're looking to see kind of what the response is in which may be different than, say, our first experimental subject who presented with fairly pronounced respiratory weakness at baseline and who was still able to really respond to treatment rather robustly. So a question here. Because of the progressive nature of Pompe disease, should RMST continue to maintain any improvements? And this is, somewhat related to a previous question, but I'm sorry, I got distracted by another question there. But yes, again, if we believe that RMST is exercise-based and that's where its benefit comes from, is from exercise, then yes, it should continue. For the purposes of the study which I'm conducting, we're withdrawing the treatment to make further, to more clearly define the relationship between the treatment and the response. And also the relative robustness of the response. So we withdraw after 3 months of training, and we observe for 3 months at 1, 2, and 3 months. And we'd like to see that these changes are relatively persistent, but we believe there'll be a slight declination over time. But probably, when applied therapeutically, this is, RMST would be something that would need to continue. Perhaps there would be, periods of not doing the exercise and then returning to it. But I think it would be something rather ongoing. Okay. So does Michelle have an audio question?
We do have an audio question. Our first question comes from George.
Oh, can you hear me?
Yes, I can.
Okay, sorry, I wasn't able to see any of the slides. I've been sort of restricted to just the telephone. But thank you for having the presentation. It's really informative. My son is he's an 8-year-old infantile Pompe patient who is currently enrolled on a gene therapy clinical trial that looks at targeting therapeutically the diaphragm of these kids and trying to correct diaphragm so that we can increase respiratory function, so that they can hopefully, ultimately would be to come off of the ventilator.
That sounds really interesting and exciting.
Yes, it is very interesting, very exciting. He's actually, we're sort of in observational mode right now, but before the trial began, we established a baseline using RMST, or basically IMST, is a lot of inspiratory muscle strength training. That went on for a couple of months to try to establish a strength training baseline, if you will. And it definitely helped. One of my questions was going to be if you had seen anything with kids on ventilators, but somebody else already asked that question. So I guess I could offer what I've seen from my son, who is on a ventilator and has gone through at least a couple months of respiratory muscle strength training, is that it definitely helped. Just in my own opinion. I mean, not really even in my opinion, but we actually saw numbers that coincided with an improvement. And it's really interesting to. It's like lifting weights, with your lungs or with your diaphragm, and
exactly right.
Yeah, you basically go through it the same way. You do sets every other day. I felt like I was at the gym. I'd be encouraging. I'm like, you got this one. Come on, 2 more.
Absolutely.
Yeah, and it certainly worked. So that really was one of my questions, is that what do you think about infantile kids and kids on ventilators, and you answered it appropriately as far as in the future. We could certainly see that coming, and I hope to be able to report positive findings with this gene therapy. It's really exciting. But one of the questions I had for you with your study patients, if you had seen a correlation between better numbers that would coincide during one of their ERT infusions. In other words, did you see a spike or a decrease if they did going in to establish a number, whatever day it was when they'd come in to establish a number or do the test? If it was near one of their infusions, if you saw a difference that maybe you could relate or pin on their infusion.
It's rather difficult for us to do that. We always kept their schedule basically the same. So if they were seen on an off-treatment week, they continued to see us on an off-treatment week. Same thing, some people, for their scheduling, it would work better for them to come during a treatment week or a non-treatment week, depending on what their own individual situation was like. But that makes it real difficult to begin to tease out the effect of a ERT. With the strength enhancements. But, if we really look at the data, the strength enhancements that we've observed really seem to be much larger in magnitude than we would typically anticipate with ERT. Now, there may be some sort of synergistic effect between RMST and ERT2, which we're exploring as well. And certainly, at the very least, ERT provides an entryway to be able to perform RMST. Does that answer your question at all?
Yeah. I think that, like you said, those numbers, 70%, 70-some-odd% increases are really incredible numbers. It's really nice to see. And one of the things that, with the gene therapy trial that people have seen with some of the patients, that there's actually a neurological involvement with Pompe as well, where, and I can't, it's not in all Pompe patients, but certainly they've seen it in mouse models and some patient models where there's actually the nerve cells are infected. So one of the goals of the gene therapy is to not only correct the diaphragm, but also to help establish a better nerve conduction. And that's something that's certainly more experimental, but it has been noted in people. They just don't know, I guess, what the percentages are. Is it some of the more affected patients, or where does the nerve involvement come in? And it's still kind of sort of a mystery as well. But it's really encouraging to see the data that you guys have. And I guess one of the questions I had is, what's the longest duration you've actually had a patient on RMST? Do you think if they just stayed on RMST that their numbers would just stay elevated the way they are?
I think there'd probably be an eventual plateau. And in one of our clinical cases, I believe that the subject had plateaued, and there may be a variety of factors involved with that, including motivation and things like that. I think that for most people, a continuous course of RMST might be a little bit too much. I think the thinking might be to try to build people up and really get them strong, and then go to a program which would, allow those to be maintained without such an intensive training schedule.
Sure. Okay. Well, that'll be really, really interesting to see. Okay. Well, thank you very much for taking my call.
Thank you. Okay, so a couple other questions here. We are recruiting. There's a question here. Are we recruiting patients for the kind of single subject patient studies you mentioned? We are recruiting studies. We are recruiting patients for this research which is ongoing. Absolutely. Okay, I'm looking over a couple of questions here. Someone asks, what steps do you recommend? I have late onset Pompe disease, 65 years old. My pulmonary doctor is just in the mode of a PFT every 6 months. Pompe is unknown to most of the medical field in my experience. What is my next step? And that's a difficult question for me to answer. Right now, these data are extremely preliminary. Our research is ongoing. I think it would be a little bit aggressive to say that we need to implement RMST in people with Pompe disease across the board and things like that. So in terms of an exact next step, it's really difficult to say. I'm not ready to tell people how to do this and just kind of let it go. I think we really need to monitor the response to treatment closely. And I think right now, if your interest is in some sort of RMST type program, I think that's going to be largely limited to experimental work right now. I don't know if this entering the clinic is really so far away, but at this point, it's just really not a clinically available treatment. Someone asked me, MIP and MEP, maximum inspiratory pressure and maximum expiratory pressure, are tests not normally performed as part of clinical measures of respiratory function. Have we looked to see if PFT, pulmonary function tests, such as FEV or FVC, also improve? And we're still exploring those relationships. In our clinical studies, there appeared to be stability in pulmonary function tests, which in a progressed disease could be considered a positive sign. In our experimental work, we're still looking at those relationships. If you look at models of the relationship between MIP and MEP, which are pressure variables, and standard pulmonary function tests, such as FVC, which measure lung volumes, as lung pressures increase, lung volumes seem that they should increase. But I don't know if that's the case or not at this point, really, to be honest with you. So that's something we're going to continue to look at as we explore. Someone else asked, if recruiting patients, must they be local, or can you work with the patient's doctor? Well, and this is a pretty common question. People are excited when they hear about a new approach to treating respiratory weakness, and many people are interested in participation. I think that we may not be too far away from, where this is something that could be rolled out and be a clinically available treatment. Right now, though, it would be sort of impossible for me to ethically work with, say, a patient's local physician and give recommendations and such about what they should be doing in terms of exercise, because we still know, we're still learning so much about it. We're learning about what the individual dosage should be. How many days a week should someone exercise? At what percentage of their maximum should it be? And those are things that we're still learning about. So I just don't think that it's really possible right now to conduct this work in that manner. And additional challenges really are that even the equipment used are often not available in many clinical settings. So someone before had noted that MIP and MEP were often not assessed during standard pulmonary function testing, which is very much true, and I believe is a rather large oversight. But in many cases, they lack the equipment to do this. I think that an additional challenge is really figuring out what clinical group would actually provide provide the treatment and oversee it. I think in most cases it would be unlikely to be a physician doing so, but probably someone like myself, a therapist. I'm a speech pathologist by training, Again, there's training issues and equipment issues that really need to be addressed before those kinds of things, I think, make a lot of sense or can be a reality. Does anyone have any additional questions that they'd like to ask? Well, Michelle, I think we're all done then.
Great, Dr. Jones. Would you like to make your closing remarks before we leave?
I really thank everyone for joining us today, and for all the interesting thoughts and questions as well.
Thank you so much, Dr. Jones. And ladies and gentlemen, this concludes today's AMDA webinar. Thank you for participating.